Assalamu alaikum and welcome to MPT channel. Hamid, can you confirm me that my voice is clear?
Yes, sir.
Okay. As this is a free Zoom link, so I can't wait for the other participant. So I'll start with my presentation. So the topic is head and neck treatment planning, and these are my reflections. And I will try to cover a bit about 3D CRT, IMRT, or VMAT. So I'm not going to go on details of planning, how to plan. I'm not going to talk about that, but I will talk about the nitty-gritty which need to be addressed in these plannings, and also the selection of fields. That's the important thing. So the contents, these are the contents of my presentation. Um, need to understand that radiotherapy treatment can produce a good effect if it is delivered in an appropriate clinical context. The RT practices required not only excellent clinical skills but also appropriate technical expertise. Person must be aware of the principal guidelines of RT, use and benefits of immobilization devices, and also one may know that what immobilization devices available in their department and how the RTTs are using those devices on treatment units. So clinical practices are quite important. It varies from department to department. So, imaging modalities, what imaging modalities you may have in your department and the limitations. So, try to understand, don't work blindly because there are loopholes in the departments, and one may has to understand how to tackle with those loopholes. Need of treatment plan. So, optimization and dose calculation are the basics. And in optimization, one has to have a PTV coverage, sparing organ at risk, sparing rest of the surrounding tissues and shieldings. So you must follow the guidelines of ICRU. And the dose calculation, isodose distribution, review the distribution slice by slice, monitor unit calculation, keep an eye on the monitoring units as well. Conformity index, heterogeneity, and correction of homogeneity is on or not off. Option you may have a planning station, algorithm, techniques, expertise, of course, it's important, and automation. So new era, AI is coming, so we have to learn automation as well, AI as well. So head and neck cancer are among the most common cancer in developing countries, especially in the Southeast Asia, underdeveloping countries, sorry. Include aerodigestive tract, most squamous cell carcinoma. Management in terms of RT is very complex due to the presence of sensitive OARs. Immobilization device and position of neck play important role in planning. So these are the techniques, and the above two are abundant nowadays. And this is a learning curve of our Aga Khan University Hospital Department, Radiation Oncology Department. And this is my learning curve that I started in 2009 and started with the 3D CRT. And then in 2014, I learned how to make horseshoe plans and 3D CRT techniques, avoiding electron boost. And then we got IMRT in 2012. And in 2020, we started VMAT. And hopefully, we'll be going through SBRT in 2023. And also in the VMAT and IMRT, there is an option of MCO-based planning. So this is a workflow of 2D based planning, and hopefully you all know about it. And these are the typical diagrams I have choose from Faiz M. Khan book. 3D CRT planning. So this is the important part, the CT imaging with the immobilization devices and the voluming according to the guidelines. Then field setup, dose calculation, plan evolution is important part. And of course, the plan approval and double checks and APIT. And weekly review and the portal checks are important. So start with the basics, and this is what we got in when we do CT, and we started with the body contour and different ways the physicists used to do this contouring the body, and there is no right and wrong answer. And I've traveled in some of the centers outside Pakistan, and they also have a different practices. They have pros and cons. You have to learn of yourself. So what they have said, there is no clear indication, recommendation on how to delineate the body. Immobilization material is a treatment and should be accounted for inside the body outline or as dedicated structure with support structure. So in Eclipse, there is a support structure option. I don't know about the Monaco system, how it incorporate the support structures. So this is a recommendation that these structures should be marked as a support structure and they are should be contoured, not as a part of the body, because algorithm took both the things differently, and one has to understand the algorithm how it working. 3D CRT techniques, and you may aware of these techniques. This is a bookish things, and we also apply these things in our clinics. And this is the simple 3D mono isocentric, three-field mono isocentric technique with the electron boost. So one has to be aware about the electron boost when you insert along with the phase 2 volume. The hotspot will always be on the photon treatment site. These are some other techniques. This is a very interesting technique, bull-eye technique, but one has to have ideal volume for this. This is a beam eye view. And this is a 3D view of one of the plan. Horseshoe technique can be done with the monoisocentric technique and also with without monoisocentric technique, depending on the how much volume was extended on in the next site. In this case, there is a couch as well to avoid the eye, and this is how it was made. So the benefit is you can avoid electron boost, and this can be treated up to the 5,000 without exceeding the tolerance of spinal cord. And this is without monoacids center technique, but volume has to be an ideal. The lower neck volume is not much extended inferiorly. And this is also another good plan. Another use of monoacids technique and the volume, if the volume is changing on the slice, so one can avoid this region. IMRT planning. So the difference is ICRU 83 report has to be followed. The rest of the things are similar, and if you have IGRT, that will be more beneficial. The other things are the beam optimization angle option is available in Eclipse, so one could use this option for the complex plan, but the 3D CRT background helps in choosing the IMRT fields. And this is the main reason why IMRT was superior as compared to 3D CRT, the curvatures. Uh, these U-shaped volumes can be covered easily. This is I would like to emphasize that in Pakistan, mostly the centers started with 2D, then 3D, and now they have switched to IMRT. But internationally, some of the centers has directly started with IMRT. IAEA has a concern, and they published the report emphasize on about the importance of IMRT, how to switch from 3D CRT to IMRT, what are the resources are required. So one should cover this book to understand what they are going through. So forward planning, simply putting the fields and optimizing with the weightage or beam modifiers. With inverse planning, you have to give the constants to the optimizer and it will give the results. So typically IMRT 7 field, these are the angles are used mostly, and odd numbers are better. So optimization is a kind of mathematics, simply grids fill according to constant. Optimizer try to get the solution, and if the solution was not correct, then iteration will continue. In Eclipse, for the IMRT, they are using the gradient-based method. So this is the comparison between IMRT and 3D CRT. This is the IMRT plan, and you can see the 3D CRT plan. The cautions are use normal tissue objectives. So the low dose region can be reduced, and one has to evaluate the plan properly when you're using IMRT. And the hotspot, keep an eye on overdose area. So cautions, avoid opposite angles, call emissions, 5 to 15 degree helps in managing hotspots. 90-degree collimation in the post field to minimize the dose to the spinal cord could be used in head and neck. Modulation is important, control muse, and in IMRT, it can be controlled with a smoothing option. So usually it's X is 40 and Y is 30, and because you're usually using zero collimation or 5-degree collimation. So X is important because MLCs are moving on the X direction. So one could change the smoothing factor and could try different numbers to achieve the result. If you have a jaw tracking option, then watch for the small segments. It may cause higher muse, and this warning message also appear when you are planning. Critically review the DVH and the report dose as per ICRU guideline. Delineation issues like the spinal cord was converged with the brainstem, so it might be an error. This could be an error on when you are evaluating the doses. So this should be separate. So first, always take a look on the how the volumes and OARs are delineated. VMAT planning. So again, the guideline is same and the process is similar. The difference is arc geometry tool. There's an option of arc geometry tool to select the arcs. So in my opinion and my experience, the previous experience of IMRT and 3D CRT really helps you to select the arc because the system generate an ideal option, uh, or maybe it's not an ideal option, but one has to understand the limitations. Usually, for head and neck cancer, when you are covering the head part and the neck part, it gives two arcs, and this is okay. But for the second volume, the phase 2 volume, it gives only one arc. But the coverage and the monitoring units and the dose tolerances are may got better with the two arcs. You can reduce the arc length without if don't use the full arc. You can use a partial arc depending on the volume. If it is a ipsilateral volume or the volume is going right side more or left side more, so you can adjust your arc. So this is what I'm talking about. The select arc appropriately, and also you can use a partial arcs, and avoidance sector could be used 260 and 100 or ending on the same gantry angle. So what it is talking about that if you want to avoid the shoulders. So avoid using a default collimation. The system also gives default collimations 30 and 330, which is I don't think it's appropriate. Use 15-degree collimation or 90-degree if you want to control the spinal cord. Use avoidance sectors in a PO as per need, and isocenter in the mid PTV is ideal. So these are the some pics of the head and neck cancer with arcs, and this is a phase 2, and you can see I've reduced the arcs on the posterior side. So depending on the shape of the volume, and again the phase 3, I have reduced more, but still I'm using 2 arcs instead of 1, because the system will give you 1 arc, 1 full arc. So we can reduce the dose or lower dose region, low dose spill in the posterior area by reducing the length of the arc. If you don't have a jaw tracking option, then don't cover the whole volume with the 1 arc or 1 field, and try to reduce the jaw. So it will give the better answer if you don't have a jaw tracking. But if you have a jaw tracking, then it will be okay. So understand the environment of the PO. You have multiple options, and this, and also you have an MU objective. If your MUs are high, you can control the MUs with the MU objective. This option is available here. And another plan information, you have avoidance sector option. You can insert the values where you want to avoid the beam on. VMAT use multi-resolution dose calculation algorithm. So I'm not going to cover about this. I have to learn more about this option. One could explore in Eclipse. Those algorithm options are important to understand. So if you are using an Acurus, then check your dose calculations. So the calculation resolution usually is 0.25. If you have a small volume, then you can go to the higher resolution like 0.125 or less. Field normalization is 100% to isocenter. Dose reporting mode is important. If you are using the Acurus, you must have dose to medium instead of dose to water. Heterogeneity correction should be on. For the AAA, these are the options only available. For the PO, there is our options of inhomogeneity correction. It should be on. Usually air cavity correction is off, so you may try with on. And this is a recommendation when you are treating the lung cases or the areas where the air cavities are there, like head and neck, you have air cavities. So it gives a better result. It reduces the hot spot on those cavities. You can also explore the aperture shape controller. This works only on a VMAT. So it's the recommendation is to make low or moderate. So there are multiple options, and you can see the details of the manual of Eclipse. Other consideration, usually clinicians make the volume to the surface, and sometimes they want bolus, sometimes they don't. But the argument is if they don't need the bolus, then they should not draw the volume closer to the skin. Um, in IMRT and VMAT, we have a privilege that by increasing the priorities, we can get the dose on the surface, but it may not be true on the treatment unit, or maybe one has to check by doing in vivo dosimetry. Um, uh, but it cause muse, it cause higher muse, and that is not good. So one should discuss with the clinician. Um, the island regions. So the volumes are kind of, this is the same patient volume in the different slices, and you can see the volume is spreading here and then here, and this is the coverage here. So these are the areas where you got some 95 or 90 coverage. So you have to make avoidance sectors to reduce the doses on these islands, because sometimes rings doesn't work well on these areas. Review the plan. Dose distribution of MRT and VMAT will be different. Even if the same list of priorities are used, review the plan with this in the mind. And if you don't have a jaw tracking, you may get this kind of stuff. So one should aware how to reduce these things. Uh, make the appropriate fields if you don't have a jaw tracking. So evolution, check Muse and modulation factor should be less than 4 in VMAT, whereas less than or equal to 8 in IMRT. MU controller option available in PO. It goes high due to the complexity of the plan or multiple time run from MR3 to MR2. So start from the beginning without changing the priority or constraint will be a better thing to do. Ring may not work well in island areas. Use small volume ad hoc structures to reduce the dose in a specific region. In overlap areas, like the parotid and the PTVs are overlap, use GOD options for OARs. Avoid hotspot on OARs, overlap regions. So what my practice is, I gives the 100% priority on the OAR, like the parotid, and 100% to zero volume. So what I am trying is to uh, avoid the hotspot on the on the OAR. So the hotspot should be in the PTV, not on the overlap region of the OAR. Caution, inspect all the slices. Look critically at the dose statistics during the review process, and one has to understand how to use DVH. Optimizer will do what you ask. Be sure to be specify priorities as the best as you can, particularly for rapid arc, review the MLC sequence as well. Adoptive radiotherapy as the venue has to explore more. Assist patient weekly basis, report gaps on the mask due to loss of weight or tumor shrinkage. CBCT helps in decision of re-CT. It's important to keep an eye on the patient performance. For those who want to learn more about VMAT planning, go to the channel link and you can find the details on this presentation video, volumetric modulated arc therapy, and it's also include the hands-on as well. Or one could go do the RCC page, and they have a very good presentations on VMAT and IMRT. Thank you for listening and for your time. And please share, subscribe, and like my channel, and also participate as a speaker. Thank you very much.